We are very glad to see you in our session, and let us to open the session, Consumers' Good Governance for Medicines and Medicines Transparency Alliance. We have, at the first part of our session, we have two presentations and discussions. After that, we have a break, and at the second part of our session, we have two presentations as well. So please keep your questions after the first two presentations. And let me introduce myself for this. My name is Natalia Chebotarenko. I am from Moldova, and I am Executive Director of CARSAM. It's Coalition for Rational and Safe Use of Medicines, mainly work in former Soviet Union countries, but not only. And the second moderator is Mr. Mohammed. And introduce yourself, please.
Thank you. Good morning, ladies and gentlemen, and good morning to our colleagues following us through live webcast from Alexandria University, Ferris University, and from the rest of the world. My name is Mohammed Ramzi Ismail. I work for the WHO Regional Office for the Eastern Mediterranean. I'm very pleased to be with you today and to humbly help with co-moderating this session for you. It's a very exciting topic. We have a few very lively presentations, so hopefully we'll be able to come out from them with some recommendations for the future research, but also for a very rich sharing of experience from these diverse countries. Apart from our four presenters today that will be presenting in a second, we have also a few abstracts that I'd like to refer to and acknowledge from other countries. So we've had Macedonia, Thailand, Mongolia. We have Richard Bergstrom from the International Pharmaceutical Manufacturing Association. There's abstracts from India, Jordan, Lebanon, and there are a few abstracts from the Medicines Transparency Alliance. We have Kenya, Tanzania, Uganda, and the USA. All of these are other abstracts that you can look at their posters on this same issue. So our first presentation is by Dr. Rasha Hamra. She is from the Ministry of Health in Lebanon and has been working with WHO for a long time now on good governance for medicines issues. Dr. Hamra will be presenting today results of an international study done in 15 countries.
That's not the
presentation, please, of Dr. Rasha Hamra.
Thank you, Mr. Chair, for the introduction. Good morning, ladies and gentlemen. It's my great pleasure to be participating in the SEOM 2011 among you all. Allow me, please, to present to you today the transparency monitoring study that was conducted as a rapid assessment of transparency in key functions of pharmaceutical services in 15 countries. Okay, I will go ahead with the presentation, and sorry for this delay. We all agree that corruption is a barrier to access to quality essential medicine. Why is that? Okay. Medicine represents one of the largest components of health expenditures. It constitutes between 20 to 50% of the total health expenditure, depending on the country. It is estimated in 2009 that the total volume of pharmaceutical market reached around $837 billion, making the pharmaceutical sector vulnerable to corruption due to the market volume and the economic interest, among other things. Corruption is also identified as the single greatest obstacle to economic and social development and to the world's efforts to reach the Millennium Development Goals. Corruption has a direct negative impact on quality of health services, wastes limited resources, and erodes public and donors' trust. Corruption can result in having unsafe medicine in the market, and this is very serious and making it a matter of life and death for the patients. And this will create more inequality, and again, the poor will be the most affected. Thus, WHO developed an innovative program, which is the Good Governors for Medicine, GGM, with the goal to contribute to health system strengthening and prevent corruption by promoting good governors in the public pharmaceutical sector. And some of the specific objectives that are relevant to our study is to raise awareness on the impact of corruption in the pharmaceutical sector and bring this to the national health policy agenda, and to increase transparency and accountability in medicine, regulatory, and supply management systems. DGM is a three-step approach. Phase 1 is focusing on national transparency assessment. Phase 2 is the development of national DGM program framework. And phase 3 is the implementation of this program. And our study focuses on developing a monitoring mechanism for phase 1. So where's DGM now? DGM started in 2004. And it's a global program that is implemented in 26 countries across the 6 WHO regions. And these countries are in different phases of the DGM program, as we can see here from the map. And we have 5 newcomers in 2010 from the Hamra region. Back to phase 1 of DGM, which is the National Transparency Assessment. This assessment was designed to provide countries with the level of transparency and vulnerability to corruption in the public pharmaceutical sector at the time of the assessment, and the results can be used to measure progress over time. The assessment evaluates key functions of the pharmaceutical sector system. At the regulatory side of the medicine chain, it evaluates registration, licensing of pharmaceutical business, inspection, medicine promotion, and control of clinical trials. At the supply side, it evaluates selection of essential medicines, procurement, and distribution of these medicines, using a standardized instrument that was developed by WHO over time for this purpose. And this instrument focuses on evaluating the presence or absence of country regulations and official documents, written procedures and decision-making processes, committees, criteria for membership, and conflict of interest policy, as well as appeal mechanisms and other monitoring systems. This instrument gives the chance for countries to revise their laws, regulations, policies, as well as administrative structures and processes at the time of the assessment. And at the end of the assessment, a report is produced on the results and having some recommendation to implement to improve these functions. So this assessment was conducted in 26 countries between 2005 and 2008. And just to give you a summary of the baseline data, just to know from where we started, and some of the common weaknesses among countries include lack of conflict of interest guidelines for all functions across the pharmaceutical system, lack of publicly available terms of reference and written selection criteria for members of various committees, lack of public access to information about the pharmaceutical sector, including legislation, regulations, and written procedures, poor enforcement and implementation of laws and regulations if they are in place, and the absence of a responsible unit for monitoring medicines promotions. So after 6 years, and in order to measure progress, WHO decided to assess the change in transparency in the participating countries of the DGM and to analyze the extent of implementation of the recommendations that were made after the baseline assessment. And the objective of this monitoring study are to develop and implement a monitoring and evaluation mechanism for the transparency component of the DGM and to analyze progress to date, to analyze data on transparency for both the baseline and the data for 2010, and to provide recommendations for improving DGM policies based on the findings from these countries and develop a new set of baseline data for 2008 for these 8 important pharmaceutical functions. I will not go over the details of the methodology here, just to say that a checklist was developed based on the original instrument with simple instructions to follow, and these were sent to DGM focal points in countries, and they were asked to participate on voluntarily basis. And we had more than 90 indicators across all the 8 functions. We had 15 countries out of the 26 who responded to the invitation to participate. These are Benin, Bolivia, Cameroon, Costa Rica, Indonesia, Jordan, Laos, Lebanon, Macedonia, Malaysia, Moldova, Mongolia, Philippines, Thailand, and Zambia. And the other 11 countries chose not to participate in the 2010 analysis for various reasons, including it was not a priority, the government was changed, the GGM focal point was changed, among other things. We found that in some countries, certain functions were not assessed at baseline because these functions were added to the instrument as it was developed by WHO. Thus, a comparison was not possible, and some countries did not fill all the functions. Some of the findings, as we can see here from the graph, the most significant improvement was seen in registration, selection, and procurement in terms of the countries that gave attention to these functions to improve. Also, some improvement was seen in inspection and promotion, and we could not assess the improvement in licensing and control of clinical trials because we did not have enough baseline data. But now with this study and this analysis, we have new data for functions that were not assessed at baseline. For example, for the clinical control, for control of clinical trials, now we have data from 15 countries. Again, some of the general findings, and we took here common indicators among all functions. For example, the conflict of interest. We had many countries that developed the guidelines on conflict of interest, and they set a form across all functions, yet no rules on acceptance of gifts, reporting of conflict of interest, protection of informers, actions in case of failure, in case of non-compliant with these policies are still not available. For the public availability and easy accessibility of documents, many countries made the existing laws and regulations available, yet decisions for committees, for example, for registration and selection, are not yet made publicly available. As for the terms of reference and SOPs, these were developed in most of the countries for registration, selection, and tender committees, yet they are still lacking for licensing and promotion committees. And for the rotation of members of committees, many countries adopted this for the registration committee, yet they are not applicable in selection committees and for inspectors. Other indicators that are still lacking, for example, independent appeal systems for registration and procurement, complaint system for unethical practices for promotion, monitoring system for performance of procurement, office, suppliers, and distribution. Various guidelines are also lacking, for example, classification of GMP deficiencies and other guidelines. Some of the functions that we found that are of high priority that need immediate attention in countries that came in number 1 is promotion, followed by control of clinical trials, and then inspection and selection. We have other detailed results, and for the sake of time, I will not be able to go through them. As I said earlier, we have more than 90 indicators, but if you are interested, you can have a summary, to have a look at the summary in the poster. Now for the lessons learned. The transparency assessment enabled policymakers to understand strengths and weaknesses in their pharmaceutical system, set priorities, and implement appropriate interventions in a stepwise approach at different levels and across the various functions of the pharmaceutical sector. This analysis showed which weaknesses were addressed most and which were given the least attention, and we need to go further to see why. And the results will be a guide where efforts can be focused next. Also, the results of this analysis and future ones will hopefully help in identifying agenda for policy change and setting realistic priorities for action in countries with regard to transparency. Changes were more seen where WHO provided technical support, for example, the conflict of interest form. And as we know that good governance is relatively a new discipline, and these are new concepts to countries, so the WHO support is always needed and welcomed in countries. Changes were seen at the Ministry of Health level, for example, development of terms of reference and SOPs, but no change in existing laws where higher level of commitment is needed. And definitely there's a momentum for change that is increasing, but the speed of progress varies depending on the country context, and this depends on the political stability of the country and the readiness of the country to talk about corruption. And of course, the GGM is contributing to the movement forward for the international anti-corruption agenda within the pharmaceutical sector, and this can be applied across the health sector. As for the implications on policies, GGM is currently focusing on strengthening the public pharmaceutical sector to resist corruption from inside and outside, thus building a system with as few loopholes as possible. And then the next step is to evaluate and to tackle the private sector, which will be a harder task and more complex. And by reducing corruption in the pharmaceutical sector, we will be having a lasting impact on countries' investment in healthcare and improve access to quality medicines for the long term. And this will reduce the waste of public and donor funding as well as out-of-pocket expenditure, thus better use of resources and contribute to improved access to medicine for all and especially for the poor. And it will improve the credibility of the public institutions, which in turn will increase public confidence in governments and in medicines available in the market, and that is provided the ministries of health. And finally, just for the future research, which is mainly focused on GGM, is that this analysis hopefully will be conducted every 2 to 3 years to allow consistent assessment of monitoring of the transparency component. And ME is part of good governance, and sharing information is part of transparency. So we need to do that. This analysis hopefully will expand to include all the 26 countries in addition to the newcomers. Hopefully it will expand to cover both the increase in transparency and the improvement in the governance as well as the other phases of the GGM. And there's definitely a need to monitor not only policy change, but implementation as well as performance. And hopefully that one day soon, we will have a pharmaceutical sector that is based on transparency and ethics. Thank you.
Thank you very much, Dr. Rasha. A very lively presentation as usual. You've highlighted some very important issues in your presentation. Some key areas Rasha mentioned have been conflict of interest and its prevalence in certain functions of the pharmaceutical system, lack of standard operating procedures for many of the committees, the access to information that's publicly available and accessible to people, enforcement of some of the regulations that exist, and monitoring of pharmaceutical promotion remains an issue that was identified. So thank you very much for presenting your study to us.
Let me introduce the second speaker. It's a pleasure to invite Mr. Tuan Nguyen. He's a pharmacist originally from Vietnam, and he's a university lecturer from Hanoi University. Recently, in March this year, he finished his PhD thesis, and now he's working in Australia at the University of New South Wales. No, sorry, it's a Medicine and Pharmacy Research Center. And now Mr. Tuan Nguyen is going to present the report, Corruption and High Medicines Prices in Vietnam, a qualitative study. This is a part of his PhD thesis.
Thank you, Natalie. First of all, I would like to thank the ISIUM organizers for providing me a scholarship so that I'm able to be here to present my study, Corruption and High Medicine Prices in Vietnam. Our medicine price surveys using WHO high methodology show that medicine prices in Vietnam were extremely high. Adjusted for purchase power parities of Vietnamese currencies in 2005, the price to outpatient in the public sector was 47 times higher than the international reference price for innovative brand, and even for lowest price generics, it was 12 times higher. More interestingly, the price in the public sector is higher than in private pharmacy, and some generic medicine was found to be more expensive than innovative brands. These shocking findings require further research to investigate the reason for high medicine prices in Vietnam and the anomaly price trends. To complement our quantitative survey, a qualitative approach was adopted to better understand the underlying causes. Semi-structured questionnaire was used to conduct 43 in-depth interviews with different stakeholders, including pharmaceutical companies and private pharmacy who set their own medicine price, and government officials who are responsible for controlling medicine prices. Based on preliminary findings that informal payments made to healthcare providers is a dominant factor, a new group of participants, namely prescribers and hospital pharmacists, was included to further investigate the aspect. And here are the findings. This slide shows the interactions of reported factors causing high medicine prices in Vietnam. Participants reported that why innovative brand was very expensive because of a supply monopoly. The price of generics was set at around 80% of innovative brand price, sometimes even higher, to recoup the informal payments that pharmaceutical companies had to make to healthcare providers, to physicians, to induce them prescribe their medicine, given the perceived low qualities of their medicines that's mainly sourced from Asian countries. This is typical examples of how medicine prices add up for a particular generic medicine. This medicine has an import price of $1, but each company sells it at $6 to have a commission for physician, 40% of the sale, big enough, rewarding enough to induce physicians to recommend this medicine. So the question is why and how informal payments occur. This slide summarizes all the reasons reported by participants that could be classified into two main groups, individual factors and systemic factors. Because of limited time, I will only focus on the most salient themes of self-interest maximization among individual factors and poor governance among systemic factors. This model was developed based on this factor, and I named it trade-off model. With self-interest maximization, participants reported that physicians weigh the cost and benefits of acting corruptly against the cost and benefits of acting with integrity, and they will choose to act in such a way that maximizes their self-interest. Here, the benefits is the financial from the corruption, whereas the cost is the risk of losing their assets. Their assets reportedly included professional ethics, personal values, knowledge and skills, reputation, advancement opportunity, and their employment. Testing the model against data shows that the higher salaries, the less likely it was that physicians would engage in corruption to risk their well-paid job. This self-interest maximization, together with the normalization of corruption, derived from the prevalence of corruption in Vietnam societies and other societal norms, created a vacuum in which corrupt practice appear to be justified and accepted as a normal practice. In this model, governance plays a role to induce physicians to face the trade-off between financial gain from corruption and their assets. If governance is poor to a level that physicians believe there will be no punishment following their corrupt practice, they would normally engage in corruption to secure financial gain. Too much discretion without adequate controls, lack of transparency, accountability, and poor enforcement of legislation creates opportunity for corruption. With the availability of opportunity for corruption, and when physicians can justify their corrupt practice, when they suffer from financial pressures derived from low salaries, they will commit corrupt practice to secure financial gain, and this leads to a dominant type of corruption in Vietnam health sectors, the main reason for high medicine prices in Vietnam. So, corruption manifesting as a collusion between pharmaceutical industry and physicians was identified as a main reason for high medicine price in Vietnam. Therefore, addressing the widespread issues of corruption, both individual factors and systemic factors are necessary prior to formulating a sound medicine pricing policies for Vietnam. My trade-off models point to a sustainable solution for this problem. To prevent collusion, two preconditions must be met. Firstly, prescribers must confront the trade-off between financial gain from corruption and their assets. Secondly, prescribers' assets need to outweigh the potential financial gain from corruption. For the first precondition to be met, there must be a strong governance. Therefore, increased governance in the health and pharmaceutical sectors is highly recommended. Strategies may include increased appropriate controls on discretionary activities, improve transparency, accountabilities, and enforcement mechanism. Given that appropriate enforcement is both time-consuming and resource-intensive, Vietnam may want to develop a service delivery market in such a way that accountability is automatically enforced as the poor quality providers are eliminated because the purchaser, the customer will choose higher quality providers, more entrepreneurial providers. To create these markets, reform in health financing where government budget is assigned to beneficiaries rather than healthcare providers is needed. For the second precondition to be met, we need to reduce financial gain from corruption. Therefore, with pharmaceutical companies, we need to reduce the pressures of making informal payments by increasing the qualities of their medicine marketers, such as making bioequivalence a compulsory requirement for drug registration. Gradually, we need to rationalize the local drug production and distribution network by tightening the criteria for license application and renewal. Ethical criteria for drug promotion need to be developed and implemented as legislative regulation with strict sanctions for violation, such as withdrawal business license. Increasingly important is to promote pharmaceutical industry self-regulation. The examples is the marketing cost of conduct for multinational pharmaceutical companies that has been enforced and proved to be very effective in Western countries. Finally, we need to increase prescribers' access by enhancing higher standards of professional ethics. Therefore, medical ethics content in the undergraduate curriculums for health profession need to be strengthened. We need to develop and enforce in Vietnam a health code of conduct and enhance knowledge and skills for physicians through continuing education programs. But most importantly, we need to establish a sufficient direct remuneration system for physicians that separates from kickbacks and commission for pharmaceutical sales. That concludes my presentation. Thank you very much for the attention. For those who don't know Vietnam, here is the map of Vietnam. And I would like to acknowledge the Ministry of Health and Education, and Ministry of Education and Training, Vietnamese government for sponsoring me a scholarship to undertake this study. And I also would like to thank all of you for coming to my talks. Thank you.
Thank you very much, Tuan, for your very interesting presentation. It was very interesting really to know how big is the difference among prices from the public procurement and prices in pharmacies you discovered in Hanoi.
Yeah, actually, in the medicine price surveys using the World Health Organization and Health Action International's methodologies, we found that it's not too much higher, but it's around like 3 to 10% higher than in the private pharmacy, and especially some hospital pharmacies, we found it's around 40% higher than in private pharmacies. And the problem is because we often take for granted that the medicine price in the public sector should lower than in private pharmacy, but here it's different in Vietnam. So the anomalies in the price trend need to be further investigated. This led to my study.
And as well, it was interesting to know about this, your idea about the investigation of different factors that influence to the corruption from the individual level to the system level. It's really interesting. And from my point of view, it was also interesting to see that from one of the methods to fight this corruption, it was your idea to improve local drug manufacture, local drug production. Yeah, can you explain a little bit more why this will lead to decreasing of the corruption?
Yeah. Actually, at the beginning of the studies, I focused on the two potential sources of information. The first is the pharmaceutical industry and private pharmacy who set their own medicine price. And the second is the government official who are responsible for controlling medicine price. So that's the ways of sampling in qualitative research. And during the process of collecting data, we also analyzed, and the preliminary findings show that the informal payments is a dominant factor that mainly occurs in generic companies and local drug manufacturers. So that's why we shift the directions of our research to the drug pharmaceutical manufacturers domestically in Vietnam.
Thank you very much.
Thank you, Tuan. We have 20 minutes for discussion before we break for coffee, and then we'll have the two other presentations. So I invite the floor to any comments, any observations, or questions to our speakers. And we'll start with Socorro, please. I'll take a few questions, and then we'll give a chance to the two speakers to respond.
Thank you, Tuan, for that very interesting study. I just want to ask what was the scope of your study in terms of who are the local manufacturers or the pharmaceuticals companies involved. In particular, I would like to ask if you were able to include in your study the local manufacturers which are partly owned by the government, and how they are interacting into all these corruption issues. Because we believe, because we know that in Vietnam, there are still around 70 local manufacturers that are supplying the public sector, which are partially owned by the government. And I'm interested to know what is the role and how they are interacting into this issue. My second point is the presentation on the good governance for medicines. It's very interesting to see how this project has progressed. I just have a little reservations on the slide that you have presented, comparing the progress in countries, particularly, for example, that some has improved procurement processes, impact on procurement and selection. I just wonder how this was assessed, because so far as I know that many countries did not have a uniform intervention. The countries that are implementing the good governance for medicines did not implement the same or similar interventions across different levels of the supply chain. So there is no way of doing paired comparisons or across-country comparisons on the improvement of procurement and selection.
Thank you. We have to give a chance to the next. Thank you very much. To the gentleman, please, in the middle.
Thank you. Thank you for your presentations. A question for Rasha on GGM. I know you only have a certain amount of time for your presentation, but distribution is a piece of that as well. And also, distribution also means strengthening the robustness of the supply chain. So I guess my broad question relative to GGM in general is, what's the role of transparency in battling counterfeit medicines and promoting the use of legitimate licensed products?
Thank you. And to the right, please, to Dr. Richard Lang.
Thank you very much. I'd like to focus my comments on Tuan's paper. I've had the opportunity to read his thesis, and I find it an absolutely fascinating insight. And he uses the quote in his presentation and his thesis, the normalization of corruption, which comes, I know, from Transparency International, talk about this a lot. But I'm really struck by this 40% payment of incentives or payments to doctors to prescribe those medicines. And I wonder, do they think it's wrong, or is it so normal? Is it the standard practice that they don't think it's wrong, that it's just the way things are, and they don't get paid the salaries, so it's the only way of surviving? And the fact that the medicines in the public sector cost more than the private sector because of this really doesn't concern the prescribers, or that the patients, 60% of whom don't have any health insurance, are paying for these medicines. In your qualitative analysis, how was the perception? Is it just normalized behavior? And if it is normalized behavior, will your interventions actually improve the situation? Because are you addressing this normalization of corruption as standard practice, as accepted activities? Thank you.
Thank you. We have two questions from the back towards the middle of the room. We'll take these two questions, give a chance for to the back, please, a little bit. And then we'll give a chance to the speakers to respond, and we'll have another round of questions if time allows.
Hello, I'm Mary Murray from REACT and Australia. Congratulations, Tuan. It's brilliant. I'm really, really impressed. I just wanted to ask you, I know you were focusing on the policy implications and the systemic diet here, but I've read some very interesting work on how the consumers think in Vietnam, how to be how to get market intelligence about trusted providers, a good price, and who's the best provider to go to. So my question is, do you think there's a way of working with consumers in Vietnam through, I'm not sure what mechanisms, but there must be, because as the lightning fast intelligence about the market, I think, is very powerful in Vietnam. Is there a way that this issue of reputation and some of the personal assets that you provided, is there a way of getting that into that very chaotic but very powerful word-to-word mouth of who is a trusted prescriber in relation to this question?
Thank you, madam. The second question, please. Yes, to the kind lady.
I am a doctoral student, and one of my dissertation is the qualitative study about the reimbursement policy for prescription drug in South Korea. So I'm so glad to see the Tuan's presentation. And my question is, what is the, is there government enforcement policy measure to penalize the healthcare providers to receive the unlawful, the kickback from manufacturers? Because last year in Korea we implemented the dual penalty policies, because before that we didn't penalize the physicians, but last year we started to penalize healthcare providers and also the manufacturers or wholesalers? And also, I'm wondering, is there the government set the wholesale markup or like retail markup? Like, yeah.
Thank you very much for these questions. We'll give the speakers a chance to respond. We'll go in order of presentation, and also ladies first. So Dr. Hamra.
I would like to make one clarification that our monitoring study was not a comparison between countries. The most important reason for this is that countries have different pharmaceutical systems, different policies, different regulations, and they definitely have different starting points. So it was not a comparison between countries to see who did better than the others. As for your question, the original instrument had a vulnerability scoring. This scoring was set by the WHO for the GGM, and this scoring is the higher the score, the less vulnerable the specific function is to corruption. And this score is calculated in a way that if you have most of the indicators in place, this means that you are less vulnerable to corruption. So we had these vulnerability scores that are at baseline. And during our monitoring study, we calculated again the vulnerability studies, seeing the total number of indicators that are now available compared to baseline. And in this way, we could see which countries and what functions were improved. And definitely, countries had different ways of improving their functions, and they did not use the same methods. So I agree with this. As for the second question, again, this assessment was directed to measure transparency in the public pharmaceutical sector. So as for the distribution, it was mainly for the distribution of medicine that are usually procured and distributed by the government and the Ministry of Health. And the distribution focused on the storage of these medicines, the shelving, the transportation, and how the ordering is connected from the central warehouse, or if we have decentralized centers, and between the healthcare centers and between the public. So the counterfeit was not part of the original assessment. Thus, it's not part of our monitoring study. So we did not tackle this issue. Thank you.
Thank you very much. One small addition to what Rasha just responded to on the second question. We didn't, in the GGM program, WHO has not looked at the counterfeits and how good governance or bad governance is affecting their availability in the market. However, some of the countries did report that the distribution chain was one of the main channels of entry of counterfeits into the public systems. And in that sense, the countries that have improved the measures of security within the distribution chain, they also aim to improve to decrease their vulnerability to that entry point for counterfeits. Thank you, and please, Tuan, to you.
Thank you for the interesting questions, and I will address the questions in the order. First, to answer shock, yes, you raised the issues about the roles of governments, the pharmaceutical manufacturers. Yeah, actually, at the moment, Vietnam has 171 domestic pharmaceutical manufacturers, but their problems is, according to one report, I have data here, so that only a few domestic pharmaceutical manufacturers are technically and financially capable of competing with foreign manufacturers. They lack of investment. Of course, the technology is increasing, developed, and they expand their business scale. However, it's still very in small scale and very difficult to compete against the multinational pharmaceutical manufacturers. The second problems of domestic pharmaceutical manufacturers in Vietnam is the inability to produce raw materials, raw pharmaceutical ingredients. More than 90% of the raw ingredients have to be imported. Therefore, to be able to dependent from the international pharmaceutical market is out of question, because at the moment we still import up to 90% of the raw material. The next question is from Richard. Yeah, it's very painful when I found out that the problems in Vietnam, when 40% of the sale is paid to healthcare providers, to physicians, apart from other stakeholders such as government authorities for selection of medicine, for distribution, for here just focus on the use of medicine, 40%. Yeah, it's the concept of normalization, and because of the prevalence of corruption in Vietnam society, to address the problems, we cannot only focus on one single method, and we need to approach it from different aspects. Why the comprehensive anti-corruption programs for the whole society may be needed. The specific, sector-specific programs also very in it. And I think firstly, we need to improve the governance. We have to show the physician that, okay, if you commit corrupt practice, then you will be fined. For example, some solutions such as contractual arrangement with providers such that the loss of the healthcare of the provider number or the like is a deterrent to accepting informal payments. Because here the problem is all the physicians believe that, oh, I commit corrupt practice, but no punishments will happen. So I think at the same time we address the problems of governance, but also we have to reduce the pressure for corruption from the physician point side by increasing their salary. And I think that it's very difficult to increase the salaries in the whole societies, but given the importance of the health professional, yeah, we may need a special remuneration system for physicians and to address the problem. And it will have to improve the rational use of medicine and improve the health of the whole society. For the questions about the consumer's intelligence, in my suggestions, in my thesis, yeah, I also recommend that we need to improve the patient choice, improve the knowledge of the consumers so that they know who is the best providers. And also I recommend in my presentation that Vietnam may want to develop a service delivery market in such a way that the accountability is automatically enforced as the purchasers will choose higher quality providers. However, it's very difficult, even in developed countries, not mentioned Vietnam, a developing country where the standard of intelligence is quite low. The last question is about the enforcement issues. Yes, in my model, I also say that the enforcement is one component to improve poor governance, because we often view enforcement narrowly as a way, a strategy to fight corruption when it occurs. But the poor enforcement itself is an opportunity for corruption, as I mentioned before. Therefore, we need to enforce regulation and legislation. With you also asked me, how about the wholesale and retail markup? Yeah, Vietnam does have the regulation for wholesale and retail markup. However, the problem is enforcement, and also because we haven't found out the way to set up the how much is the markups for each point in the supply chain. So it's just in the paper. Yeah, we asked the Ministry of Health and Ministry of Finance to control the markup, but how much for wholesaler, how much for retailer, we haven't identified. Thank you.
Thank you very much, Tuan. And we have just enough time for a very short round of second questions.
We have very important participants. Good morning, Alexandria, and we are very happy that you are with us. And Alexandria sent a very interesting question to both of you. To what extent do the study findings reflect the real status, the real situation? Please, you answer.
I guess for the transparency assessment and the monitoring study, it reflects well the reality. We are measuring whether a policy or a law or a regulation are in place. We are not measuring the performance or the outcome. We are measuring whether a policy and the process is there in place. And I guess the way the instrument and the monitoring checklist was set, it reflects very well the reality in countries.
Thank you very much. So you assume it's about 99% of the real situation or less?
I cannot say that. Maybe it's up to the country to decide whether this is true or not.
Okay, thank you very much. And Tuan, your answer?
Yeah, thank you for the interesting question. And this is against the issues, the debate in terms of the quantitative and qualitative methods. With qualitative methods, we don't assess the accuracies of information. We just report what the perception that the stakeholders think have in the society, in the field. And also we report the findings here to raise the awareness about the problems. And I think one of the way we address the validities in qualitative methods is the way we select samples. And in my studies, I selected samples by combinations of purposive and snowball sampling technique. And based on the I build with my previous participant informant. Then they introduced me to the next one to further investigate the themes, the problems emerged in the previous interviews. And one interesting quote from my participants, they said that, Tuan, we tell you all of this is because we believe that this problem has existed for decades and nobody do anything. So when you can do something, our hair has turned white. So the issues of enforcement, yes, make people like assistant with the penalties. Thank you.
Thank you very much, both of you, for your answers. And now keep your question, please, after coffee break. And please, we would love to invite all of you for the second part of our session. We really need you, and remember, we need to develop our recommendations and key researches for the future. And now we have a break for 25 minutes. For 10 minutes? Okay, for 10 minutes. for 10 minutes, okay? Just for 1 cup of coffee, and please come back. And we have 2 very interesting presentations more, and we hope to have the discussion as well, and very useful. Okay, now it's a time for the break.
To our session. We'll start with our 3rd presentation while we wait for the rest of our colleagues to rejoin. But to allow some time for interaction and discussion, we'll go ahead and start with the 3rd presentation now. And I'm pleased to present Dr. Saad Naffa. Dr. Saad is National Professional Officer in WHO Jordan. She's played a major role in both initiatives, the WHO initiative on improving good governance for medicines, and also the Medicines Transparency Alliance, which is supported by DFID. In Jordan, it was one of the few countries that had both initiatives taking place at the same time. The 2 initiatives have the broader vision of improving transparency and reducing corruption in the pharmaceutical sector. They have distinct sets of activities, and in Jordan it was a very interesting process of trying to combine and create synergies between both. So, Dr. Saad, please, the floor is yours.
My presentation would be what is beyond. Jordan was one of the first countries in the region, maybe in the world, that were interested in the governance issue. And the government of Jordan asked officially to be one of the countries implementing the good governance in medicine program. It started in 2007. And we did the transparency assessment, and it was published in 2008, and it is on the website of WHO. Now, this work, I'm going to present a work that was done in a partnership, multi-sectoral, multidisciplinary approach. It was led by the Jordan Food and Drug Administration, in cooperation with the Ministry of Health, with the Joint Procurement Department, with the Anti-Corruption Commission, with the Ministry of Public Sector Development, with the Jordan University Hospital, with Royal Medical Services, and with NGOs and civil society. So this partnership was a very successful step in doing partnership work together in Jordan. Jordan is a low middle income country. The population is 6 million plus, and 10% of the gross domestic product is spent on health, and more than 30%, it's 34% on medicines. The government share is 43%. The private sector is an important partner, and they have more than 40% share in Jordan. The medicine expenditure is growing rapidly. It's the annual growth is 17%, while the GDP growth is 2.3%. The assessment, as I said, was done in 2007 and published in 2009. It's on the website. After the assessment, there was a national workshop, including all sectors, all stakeholders, to discuss the results, the findings, and to put forward a strategy of what is behind the transparency assessment. Of course, the transparency assessment, Jordan, as most of other countries, health promotion was the most vulnerable, severely vulnerable to corruption. And other areas, registration were in a better shape. So there was consensus that Jordan is almost like many other countries, the health promotion is an issue. and there is no conflict of interest forms or policies within the important committees working in the key functions of the pharmaceutical sector in Jordan. So the recommendations were very important of this successful workshop. There was recommendation to revise the laws, the administrative structures and procedures based on the findings of the transparency assessment. There was also recommendation to develop a national ethical framework for promoting the good governance in medicine, regulation and procurement through a consultative process. There was also a request to socialize the national ethical framework within the system, to start training, socializing, producing TV spots, documents, and introducing the concept within the public sector as a first step. There was also a recommendation to form 2 committees, and these 2 committees were a very successful step. It's really a good milestone in the process of introducing the concept. We established 2 committees. One is the steering committee, which was at the highest level, headed by Minister of Health, head of the Royal Medical Services, head of the private pharmaceutical companies, head of parliament. It was very high level presentation. At the same time, we developed also a task force, and the task force was a mid-level managers who are involved in the key pharmaceutical functions within different sectors. It was a multidisciplinary task force. They worked together for they met every week, and they developed the national framework for good governance in medicine. As I said, 2 committees were formed, and they started to work on the framework. The framework is on the website of WHO. It is the first, it's in English and Arabic. It's the first framework in the region, and you can see it on the website. And one of the recommendations of the framework is to develop the code of ethics and conduct, which was enforced for the civil servants. Now, in our search, we find that there is a code of conduct, but it is not activated. It is in the Ministry of Public Sector Development. There is something in the Civil Servant Bureau, but it was not activated, it was not used. People were like recruited, but they don't know about it. The conflict of interest consent was introduced, and it was like a standard for all committees working in the key pharmaceutical sector, especially registration committees, pricing committees, the licensing committees. So it was introduced as a standard form. There was also guidelines on health promotion developed mainly by JFDA with partnership of other sectors. This is the framework which you will find on the website, and this shows the partnership in developing the framework and the introducing the concept within the public sector. The framework was adopted in 2009, April 2009, and there was also revision with the regional office and the headquarters to the main transparency scoring. And we found in Jordan that health promotion has improved. Almost other areas were not changed. There was also the selection also improved from marginally vulnerable to minimal vulnerable. Distribution decreased a little bit. Now, after that, we had an action plan, how to socialize, how to activate the framework. The action plan included a number of activities, which were adoption of the code of conduct in the pharmaceutical sector, development of conflict of interest guidelines, development of the whistleblowing mechanism and safeguard document, Preparation of a document for all anti-corruption laws and regulations and documents. Now, what are the lessons learned? This is the old one. Okay, the level of commitment and enthusiasm within the task force was really very impressive. And even when we finished the framework, we asked them that we might review the consistency of the task force because it's a different stage. And all of them, they say, please, we want to follow up. We want to be a part of the socialization of this framework. Now, the regulatory system, there was a bits and pieces of laws and regulation, but it was not system-based approach. So there is a need to have a system for all regulations within, inside or outside the public sector. Like we found in the law that there is a lot of concern about the private sector health promotion activities, but less and the amount within the public sector is minimal. It was not addressed adequately. And another lesson learned is also the partnership. Partnership was very successful. Now, I will not go into the details, but this shows the code of conduct, the areas like the general duties, responsibilities of public servant, the relations with others. The code of conduct went into the details like the professionalism, the impartiality, integrity, the accuracy, confidentiality issues, the respect, avoiding any discrimination, maintaining confidentiality mechanism, acceptance or requesting gifts. So it is very detailed, and there was a special code of conduct for pharmacists within the public sector. The conflict of interest also, it was introduced into all the committees, into all the high-level managers, and now they are working on the management system for conflict of interest. If there is a conflict of interest, what shall we do? What are the criteria? What is the description? What are the options for management of conflict of interest? A document have been drafted, and it is really a very good work, and we have a legal advisor and the Anti-Corruption Commission in the committee working on these documents. Management of conflict of interest for the advisors within the GFDA, the Ministry of Health. These are the details. I will not go into the details. You can find the presentation later, I think, on the website, or I can share it with you. Compilation of anti-corruption legislation. This was also interesting exercise because we went into all the public health laws, the pharmaceutical laws, all the legislations that is related to pharmaceutical business in Jordan. It was compiled, and we will have a document to show where are the gaps and what we need to do about it. The whistleblowing mechanism also, it was developed. What are the areas how we can protect the whistleblower? What should be done? How is the mechanisms are in place to make sure that the system encourages and improves the management of whistleblowing within the system. Next activity, we will have a number of promoting activities to work on a training manual in moral leadership, and to have a part of it in the universities, to introduce the concept in the pharmaceutical colleges and in medicine, nurses to know about these concepts. And there is also a plan to have control of drug promotion, to have a monitoring and evaluation system for drug promotion activities, and to improve the quality of services in transparency and accountability performance, disclosure and having like a newsletter every 6 months and having events that will promote the people who have good behavior, the people who can like be a champion in this business. And this is Petra. This is important figure in Jordan. For those who did not come to Petra, I encourage them to come. And thank you.
Thank you very much, Sana. And Petra is indeed something to visit if you go to the Middle East. Sana, in her presentation, highlighted a couple of things that I'll just touch quickly upon. The JFDA in Jordan, they did a very pioneer thing for the country by introducing the mandatory signature on all committees of the Conflict of Interest Declaration. And I think that was a step which is more or less a precedent to make it mandatory within one of the institutions working on health in Jordan, so that's something that's appreciated. They've also been very forthcoming in acknowledging that the declaration has been made mandatory, but the decisions on how to deal with declarations on conflict of interest, this is a work in progress, and there are indeed very important decisions to be made on that because of the limited pool of expertise also available within small countries. Now, there's also something very useful that came out of Jordan, which is the legislation's review, sometimes within the Medicines Act or law and within the pharmacy, within the Health Act or law. We've found in countries that the enforcement or even the punishments are weak. But sometimes there are other laws outside the scope of medicines and health that include clauses that can be used for enforcement of certain penalties, and this is something that the Jordanians have done quite successfully. So thank you very much, Dr. Sana.
And it's a great pleasure to invite the next speaker. It's Professor Rahini Fernandopouli. She's my colleague. She's professor in clinical pharmacology, faculty of medicine, University of Colombo, Sri Lanka, and advisor of the Ministry of Health as well for Sri Lanka. Please, your floor.
Thank you. And I also take this opportunity to thank the organizers of ICEM for having given me the opportunity to come here and also present my findings. Now, all of you all, I'm sure, can remember the tsunami that hit 4 countries in 2004. It was Sri Lanka, India, Thailand, and Indonesia. And it was one of the worst disasters that we ever had in our country. We are generally not prone to natural disasters, so this was very unexpected, and we were not really, we didn't have any guidelines in place when it hit Sri Lanka. However, the very next day after the tsunami hit, which was on the 26th of December 2004, on the 27th of December, the Ministry of Health put out a list of medicines, only of essential medicines, around 30 to 40, that the country needed and would like to have as donations. So as in other countries, when disasters hit, people think that they must do something useful for the country that is badly hit by a disaster. So we received donations of medicines throughout, for the, I think, 3 months after the tsunami, and it came in, tons of medicines came into our country. So we decided to look at what these donations were and how useful they were for Sri Lanka. Then we also looked at the literature on what is known on medicines donations. And I would like you to focus on the 4 criteria or the main complaints that were really identified in 1980 following donations that had gone to Guatemala and Guinea-Bissau in the 80s. And the main complaints were they arrived after or near expiration, they were inappropriate or unsuitable to the recipient country. They were sent without asking the recipient about their needs, without prior notification or shipping documents, and they were inadequately packaged or labeled with no prescriber or patient information. Then following this, in the late 80s and in the 90s, guidelines were developed. It was first developed by the Christian Medical Commission of the World Council of Churches, but then the World Health Organization decided to put out their first edition of the guideline in late 90s. And because they thought that if the World Health Organization and other international organizations had separate guidelines, that this was also leading to problems, because in spite of the guideline that was there put out by the Christian Medical Council, the scene did not change. So the WHO put out the second edition of their guideline in 1999 with the collaboration of all the agencies involved in donations. So this was the guideline that was put out by the WHO in 1999, and it was under 4 categories of selection. Selection of donation should be based on express needs of the country, should appear either in the National Essential Medicines list, or if the country does not have updated Essential Medicines list, on the WHO model list, and donations of vaccines should be directed through a responsible agency. Then on quality assurance and shelf life, the guideline states that drugs issued to patients or free samples to health professionals should not be donated. And donated drugs or INN should be approved for use in the recipient country. And importantly, that they should have a remaining shelf life of at least 1 year after arrival. Then the third criteria was presentation, packaging, and labeling. Guideline states that it should be labeled in a language that is understood. It should contain INN, batch number, dosage form, strength, name of manufacturer, quantity in container, storage conditions, and expiry date on the label. And the drugs should not be mixed with other supplies in the same carton. And finally, the guideline on information and management states that all costs of international and local transport, warehousing, port clearing, storage, and handling should be paid by the donor. So we decided to look at the donations and the adherence to the 1999 guideline, because by that time, the guideline had been in place for 5 years. So I'm not going into details, or it's a descriptive study. We just looked at all the donations, and we classified them according to the ATC classification and looked at adherence to the guideline. And these are the results. There were 278 donors, 98 from local individuals and organizations, 150 foreign organizations, companies, pharmaceutical companies, and individuals, and it came from over 30 countries. And these 30 countries included countries that had guidelines like Australia, New Zealand, USA, already in place based on the WHO guideline. And as you can see, 86% of our donations were under names of individuals. And they were all ad hoc collections of medicines from individuals. And in fact, they were also transported even via International Red Cross Federation. And the total weight of these donations, now by the time we started our study, 150 tons had expired and had to be destroyed. So we only looked at the 55 tons that were left. And there were total number of single units, there were 248 million. And the number of INNs, 769, when we had only asked for about 30 or 40. And this, from the products, the oral products were 71% and parenteral 15%. And in Sri Lanka, the number injured in the tsunami was around 5,80,000. And the medicines, if you calculate per person, it would have been 434.65 units. And also I would like to emphasize that after the tsunami, there were hardly any epidemics. We had about, I think about 500 cases of viral fever and possibly about 100 odd cases of diarrhea, 135 cases of diarrhea, nothing else. Because either they died or they survived and there was no issues. What they needed was accommodation, shelter. When we classified according to the ATC classification, you can see the drugs fitted into all the ATC categories. The top 5 were anti-infectives, and drugs for nervous system, cardiovascular, alimentary tract, and respiratory tract. We also had vaccines that came in, hepatitis A, B, and influenza and tetanus, and these did not come through a responsible agency. It was individuals who brought it, and they were going to the tsunami-affected areas and trying to inject people. And in fact, the ministry had to put out a letter stopping that practice. And if you can see the inappropriate donations that came in, we had anti-cancer drugs, drugs that were withdrawn, we had radio-label products that came in. And if you look at the selection, only 20% really were from the Ministry of Health Express list. At that time, our essential medicines list was not updated, so we looked at the WHO model list, and only 35% really was from the WHO model list. 68%, because the Sri Lanka, we use a British national formulary a lot, 68% were included in the BNF. And the hospital formulary is a wider range of medicines. HFF stands for the hospital formulary. So 47% were included in the hospital formulary. And quality assurance and shelf life, now right from the beginning, 50% of it was without an expiry date of these 55 tons, so they were not usable from the start. And if you look at only out of the balance of 50%, 69% have their shelf life of over 12 months. So around 57% were unusable from the start. 2% were free professional samples, 38% of INNs were not registered in Sri Lanka. And out of the language, as you can see, 62% of the labels were not understood or readable by the doctors or the pharmacists in Sri Lanka. Information and management, if you look at, 150 metric tons had to be destroyed, and the Ministry of Health did not have an incinerator, so they had to go to a cement factory incinerator and get it destroyed, which cost the government of Sri Lanka 2.6 million. All the costs of local transport, port clearance, storage, handling, all met by the Ministry of Health in Sri Lanka, not by the donor. And I don't know how many of you have looked at the abstract that was there, 773. You can see a huge certificate that was given by one donor claiming that it was equivalent to 50% of our budget for 2005. But all the donations reduced our drug budget by only 4%. Really, when the certificate was given, they brought these huge boxes and gave it to the ministry, but nobody opened it. Only after they went, we opened it. So they got a certificate, and they got the Minister of Health and various people to stand by and took photographs to show that they had donated that value of goods. And storage, you can see that we did not have proper storage facilities, and the people inside it are without shirts because it was so hot. So the key messages are that one of the problems we encountered was that we did not have a national policy on guidelines on medicines before the disaster, and at that moment of time we were not even aware of the WHO guideline. It was after we started the study that we looked for guidelines. Then soon after the disaster, it was known that most of the medicines are useless, but the country could not do anything because they had already arrived at the port, and we had to clear it. So the WHO guideline is clear, it is comprehensive, it is practical, and can be implemented, but people have to follow it, and even the recipient should know about it. Now, few governments asked the Ministry of Health what they required, and they had adhered to the guideline, and the few medicines that came in were 100% usable because it complied to the guideline. So this WHO guideline in 2004 had been available for 5 years. But if you look at the countries that were affected, the two countries, India and Thailand, because they had a previous experience of this, simply said, don't send donations. But Sri Lanka, we did not have any experience, and Indonesia, Bangladesh did not probably have experience. So they were left with this burden of useless donations. So policies, I think immediately we should disseminate all the findings, and the WHO should select medicines donation as a theme to raise awareness on the extent of the problem, as natural disasters are always occurring. And send out short messages, if possible, through the media when disasters occur about the availability of the guideline and adherence. And all regulatory authorities should, I think, give a clearance certificate prior to shipping of any medicines as donations to countries. So the regulatory authority of that particular country should be responsible for the medicines sent out of that country. And all public and organizations should be educated on good donation practices. And probably a website for reporting bad donation practices, and local WHO officers also to take some responsibility on raising awareness on good donation practices. And for future research, I think we should do some research on knowledge of the governments, international organizations, and the public. And for public, I suppose we could put in something in the book on the WHO book on how to investigate the use of medicines by consumers, maybe a short paragraph on donations. Thank you.
Thank you very much, Professor Fernandopoulou, for your very interesting presentations. And at the beginning, I was thinking, what is the link between good governance and your presentation? And now it's very clear for all of us, it's a bad drug donations or bad governance of medicines. And I really like that you switched the topic from the internal analysis of the governance inside of the country to the donations or to the international organizations. And probably this is one of the reflection of our workshop. We have to think about the good governance in medicines, not only from the country's perspective, but as well from the international and donors organizations. And it's, of course, it's the material you presented and pictures and data, it's amazing. And in our countries, we don't have disaster in Moldova, for example, but it's still we have a problem with bad donations, with vaccinations. And when we receive this very short expiration date, and sometimes even we have donations for medicines with less than 1 year expiration date. So thank you very much, and I think your report should be reflected to the to our key messages from our workshop as well. Thank you very much.
And we'll have, please, a round of questions, comments, observations from the floor. This will be for about 15 minutes, and then we'll leave some time at the end to discuss with you the main research questions we want to bring forward on future research, and this will be recommending from this group to the ECM organizers and scientific committee. So we have one question carried over from the last session, and this is Mrs. Clara, so if she's available, we'll start with that one. Okay, if not, then Madam in the middle, please.
Thank you. It's carried over from the first observation, but I'm not that person. I'm Rosalind Kirika. I'm from Kenya. And my question was on the study on transparency. And it's more a concern, and I don't know whether you observed this in any other country, that in the process, one of the points you put across is that transparency in procurement is actually increasing. And I wanted to note that, yes, in Kenya it's increasing, but there was another kind of a side effect to that in the process, the appeals mechanism caused a tremendous delay in some of the procurement, effectively meaning that some of the drugs that were held up in that particular tender then went out of stock. And this erodes government's support to the transparency processes. So I'm just wondering, was there an observation like that in any other countries, and that it's an area of concern that perhaps we would look out for. Thank you.
Thank you very much. Question to the left, please.
Mohammed bin Shahna from WHO, Emro. Thank you very much for this nice presentation, and actually it's just a comment. This presentation shows how donations becoming problems for the countries. It's not a present, it's not a gift, it's sending problems to the countries. And actually, I think here also, the issue and the point of the role and the function of the regulatory authority in the country, and how to be functional and how to not accepting any unwanted medicines, despite, I mean, if there is a need. If somebody is going to send you a problem, you are going to pay more money or from your budget, etc. And I think, I don't know how much that figure of 2.6 million Sri Lankan, I don't know what's your currency in US dollars. So just, and this is my message, or the message the country should also always take in consideration, not to accept any unwanted medicines. And this is also for us in our region, because now a lot of countries in our region are in crisis, and they are also receiving donations, and we are trying also to support countries, sending them also these donations. Some of these countries also adapted and updated and developed also their national national donation, and we would like also to follow up with them to document this experience. Thank you very much.
Thank you, Dr. Muhammad. We have a question towards the middle front here. The lady, please. Can we have the mic here? Fourth row, the lady.
Thank you very much. Beverly Snell from Australia. I've been involved in developing donation guidelines as a result of experiences for many, many years, and the problem doesn't go away. I just want to make the point that it's really important to involve the customs authorities when you're developing the guidelines, because the guys in the customs are the ones who get the first contact with what's being sent in the country, unless they're aware of exactly what they have to do with it. Sometimes they say, oh, well, there's a disaster, let it through. But if they have the authority to refuse to let something come into the country and tell the people this is going to be confiscated because we have no authority to allow this into the country, perhaps an experience of having your donation confiscated would help in the future. I would like Rohini's comment on that.
Thank you, madam. 2 chairs to the back, please.
Thank you. Peter Pitt, Center for Medicine and the Public Interest. Dr. Sana, excellent presentation. JFDA is not only a leading regional regulator to leading global regulator, and clearly, relative to transparency, the first step is to stop unethical practice. But maybe as a research agenda suggestion, a next step is, once unethical behavior is stopped and identified, how do you capture those resources to more effective healthcare information to patient efforts in country, in partnership with industry as well?
Thank you. And to the right, Richard, please.
Mohammed, I would encourage you to read the report. You can download it from our WHO headquarters website. The methods are there. It's very clear how they've done their study. But I would like to comment a little bit on the study, because it sounds as though the donation guidelines failed. And I would suggest they didn't. The situation was much better than before. 86% of the donations came from individuals. 0% came from multinational pharmaceutical companies that were in breach of the guidelines. There's a partnership for quality medical donations, and they followed the guidelines to the absolute letter. The final point to make very quickly is Sri Lanka is next to the largest producer of generic medicines in the world. Not a single factory, warehouse, supply depot in Sri Lanka was destroyed by the tsunami, as far as I know. The medicines were actually in stock. And if the money had been provided to the Ministry of Health and said, here's the money, the 2.6 million that you wasted on destroying the medicines, then they would have been able to buy them out of stock and have them at the facilities immediately. In Indonesia, they redistributed medicines from all of the existing health facilities, extra stock, and within 3 days they had fully restocked the health facilities in Banda Aceh in that way to do that. The final point you didn't mention is the environmental impact. I saw it on your slide, but the environmental impact of destroying. If you confiscate 55 tons of medicines, how do you destroy them? And in Bosnia-Herzegovina, it took 7 years of an incinerator working 24 hours a day for 7 years to destroy these medicines at the EC high temperature standards. So it's a very real cost to the country, but also to the environment of these unwanted donations. So I think in terms of the research agenda, I would like us to have a standard method for measuring the impact of the disasters and donations. And my belief, if anybody asks me, as I say, never send medicines, send money. People in the country know how to spend money.
Thank you, Richard. And 2 steps to the gentleman behind Richard.
Okay, thanks, Mr. Chairman. I'm Ronjo from South Sudan. My question is going to Sana from Jordan. For last 5 years, South Sudan has experienced a lot of malpractice in the area of procurement and distribution of medicine, because I think because there is no clear rules and legislation for that practice, because it's just they finish the war and then they've got themselves, they have to supply medicine for the people. What the important things I want to mention here is that we face difficulties from the partners. And you mentioned something good, that there has been a successful relationship between you and the Jordanian and partners. Example is that there's a lot of parallel procurement and parallel distribution of medicine. You get people are not getting benefit of, at the end of the day, because government is trying to avail medicine to the people, and NGOs and even those who are working with the Global Fund, they are also availing medicine. But to my experience, we found that there are a lot of expired medicine at the end, in the final destination, which could be useful to the people. So my question is that how Jordan has managed to make this relationship successful. Thank you.
Thank you, sir. And we'll take 2 more questions, one from Dr. Chris.
Thank you. Although from Sri Lanka, I will not talk on the donations, but on the general transparency. A research question. I wondered whether there could be a list of publications or whatever within a country's system that could be assessed for transparency, which is made publicly available. I mean, one of the things I could think is the drug registration committee and what are the drugs that have been registered and on what basis. Generally, the minutes of a drug registration committee are actually put up on the website, not exactly as it is, but what can be put up. That, then the other part of it is the declaration of interest made available on the website of the members of the committee. Then the other thing could be what would be the criteria for appointing members of the committee and so on. If you have a pricing body, then there are decisions on how these pricing decisions came about. Ideally, going on to procurement, that can be commercial, but a government procurement agency puts the tenders that come up and what decisions were made on that. Would things like that help in transparency? I mean, that's a comment as well as a part of a research question, to have a checklist and then you say, do you have this available? If you do not have this available, then you are not coming up to the level of transparency that would be required. Thank you.
Thank you for your question. And last question to the gentleman in the back center.
And before that, oh, sorry. We have experience from the previous sessions, and if you don't mind, we want to keep your brilliant ideas, your suggestions, and please write in a piece of paper, very short, your ideas, just to make easier the life for the main rapporteur from our session. Please, if you don't have a paper, I can pass you. Thank you very much. We continue.
Zafar Omari from Afghanistan. My question is about the drug donation in Sri Lanka. We have similar cases in our country, and some cases the donated drug 100% was useless and unused. My question is, what was the challenge that the donation guideline was not implemented in Sri Lanka? And when the donation document and packing list submitted by the donors, who reviewed, and was there any committee or department to review and then approve that? Because in my country, the problem is, usually the problem is that the donors come to the authority, and the authority is referring the document, the papers, to the central medical store. Usually there is no department or committee task force to review the packing list and then select among the donated drug. Thank you.
Thank you very much. In the same order, we'll give a chance for our speakers to respond. So Dr. Saad, please.
Well, the first question was about procurement. I think one of the major developments in Jordan was that there is a joint procurement department which is related directly to Prime Minister. They report to the Prime Minister, and they do the procurement for all the public sector in Jordan. This was really very important, and it decreased the corruption a lot. That's why we have very good scores in area of procurement. Once you have decentralized systems, so the corruption is distributed at different levels. But in Jordan, we have this central joint procurement department, and there is very strict regulations how to announce the bidding and how to deal with the offers and how to declare about why this offer was not accepted. And it is shared by a committee, and they report directly to the Prime Minister. So they are not under the authority of a minister or JFDA or someone else who might like manipulate or make regulations that are not accepted by the judicial system. Now, about the second question, in fact, the code of conduct is established not only for JFDA, the regulatory body in Jordan. It is for all the public sector service providers. It means the Ministry of Health, the Royal Medical Services, Jordan University Hospital, also the NGOs related, and all the service provider mainly in Jordan. And the conflict of interest and code of conduct is one component. Now, since the transparency assessment in 2007, guidelines were developed for the health promotion. And it regulates all the health promotion issues by private sector, by pharmaceutical companies, by other partners. So it's a multifaceted. We are trying to build the systems in front of corruption. So we're trying to take many aspects at the same time and to strengthen the regulations, the mechanisms, so it would be very difficult to breach in the future. Now, the multidisciplinary, it's not easy usually to start expanding the committees. At the beginning, the core group were 2 people from JFDA and Ministry of Health to do the transparency assessment. They did the data collection in support of WHO. Now, after that, we started to think, after the national workshop, that it's not enough. We had the media in the event, we had the private sector, we had people from like Royal Medical Services, and the first meetings, it was not easy to start inducting new people. But by time, like we start to say, okay, Royal Medical Services should be on this table. Okay, the University of Jordan. And then we said anti-corruption. The first time, what? Anti-corruption? So, you know, it wasn't easy to introduce all these partners around the same table. The Ministry of Public Sector Development. It's a new ministry. The people don't link that, oh, it should be there. But with time, the relationships were excellent. Their input were really excellent because the people who work only in the same field think the same way. So when you have somebody with legal background, he's a lawyer. And when you have somebody with project management skills, they bring into the table different experience. And by the developing of the framework, they didn't want to stop the work. They asked, we will be partners in the socialization, in introducing the concepts with you in the third phase of the Good Governance in Medicine program. Now, about the criteria
and move towards wrapping up quickly to give some chance.
Okay, the criteria, also the consent form, before, when we did the transparency assessment, many things were discovered, like the criteria, who joined this committee, what is the appropriate criteria, and what should we do, and the consent form was not at that time. So it was a systemic approach to always just cover the gaps and not allow for system breach or using the system inappropriately. And the disclosure, I think within Meta, we were lucky to have also Meta within Jordan because we had many activities and there was also a study on disclosure, what is happening in Jordan and what are the recommendations, how to improve the transparency and the disclosure process of this information. Thank you.
Thank you very much. Professor Rahini.
Beverly, to respond to your question about customs, we could have got the customs to confiscate, but still the country would have to deal with whatever was confiscated, you know, getting rid of it. So ideally, I think it should be some sort of thing has to be done from the country where it has been sent, you know. So the regulatory authority there should look at the WHO guideline and, you know, see that that is conformed to, rather than, you know, once we get it to our country, because we will still have to deal with it. And regarding the next question, the donations came to the state sector medical supplies division, and there were people handling all the customs, you know, clearance. We had people in the port, we had people in the airport. But the problem again was that we were totally inexperienced. We had no idea what was going to happen to us when the donations came in. So maybe now with this experience, we can, if we ever have a disaster again, we can use all this knowledge to do it better next time.
Thank you very much. And as we mentioned, we want to take the last few minutes before we close at 12:45 to look at the future research questions and the recommendations. So, Natalia?
Yeah, and we have only 15 minutes left, and I would love to do the next one part. We have a repertoire, and to make easy your life, probably you, Jing-san, maybe you will come here and to announce what we have already from the, if we have a list of suggestions for key researchers, and we kindly ask you to announce your suggestion and to write as well. It would be easier. May I ask you? Mm-hmm. Good.
Okay. So the key points that we got from the discussion. One is transparency assessment enabled policymakers to understand the strengths and the weakness in the pharmaceutical sector, and has had the power to initiate changes at the different levels for various functions of the public pharmaceutical sector. The most significant improvement in the pharmaceutical functions are selection, procurement, registration. Changes were seen at WHO level, but not at existing legislation level. Second is that the price in the public sector is sometimes even higher than the private sector in Vietnam. Corruption was reported as the main driver for high-price medicine supplies in Vietnam, as there are few local pharmaceutical manufacturers and technically and financially compatible with the multinational pharmaceutical companies. And third one is important factors that affect corruption at the individual level are professional ethics and personal value. And at the systematic level, that is the lack of transparency and accountability and the poor legislation enforcement. The fifth one is the WHO guidelines on donation are comprehensive and would have prevented the burden of useless donations. So these are the 5 key summaries of the evidence. The 5 recommendations for policy actions. The first one is reducing corruption in the pharmaceutical sector will have a lasting impact on improving access to medicines. Second, reducing financial gain from corruption in the supply chain of pharmaceuticals will strengthen via strengthening quality of medicines, and increase prescribers' access and relieve their dependence for survival of the healthcare services, and improved patient choices and the enforced regulation will help to decrease corruption. Third one, rationalization of the domestic drug production and distribution to achieve economies of scale and reduce waste for uneconomic competition might be a solution to reduce corruption. Last one, level of commitment and enthusiasm and partnership will play a major role in the implementation of the transparency assessment. The key research questions I got. Okay, another one for the recommendation. Ministry of Health should develop a written policy on drug donation based on the WHO drug donation guideline, and the receiving country should strictly enforce an adherence to the guideline, not receive any unexpected medicines from the donors. And the 3 key research questions or gaps I got here are one is there is a need for moving from research to put into the knowledge and into action. Second, a list of publications in countries to provide the information of the pharmaceutical sector regulation is needed. And third is there is a need to develop a criteria for selection of donors to improve the transparency.
And Dr. Chris, it's probably should you mentioned the list should be should be published and should be opened for the public. Am I right? Yeah. Thank you very much. Yeah. And yesterday we discussed as well about the research. We need to conduct a peer review research from country to countries. We also want to add to the research point. What next, please? Your suggestion for the researchers. Yes, please.
Just to our kind rapporteur, if we can add in the recommendations part to policy makers, something on the strategies for managing conflict of interest, if we can recommend that to them.
Can I have a comment and a recommendation for the donations? In Lebanon, we faced the same problem of having inappropriate donations after the war that we had in 2006. And one of the problems that we faced, that in addition to expiry of the medicine, is that it came in languages that we couldn't read. So what I would suggest is that to have a code of ethics based on the guidelines that are developed by WHO, and ask countries and organizations and manufacturers to sign this code of ethics before sending any donations to countries in war or disasters, and to blacklist countries and organizations who send such inappropriate donations, because it's so much easier for countries to get rid of their pharmaceutical waste by sending them as donations, and it's not just done on the individual level. Thank you.
Thank you very much. Yeah. Microphone here, please.
Thank you very much. Following on from those comments, I think that we need to also bear in mind what Richard said, that the pharmaceutical companies learned about the guidelines and organizations largely did. It was individuals. So we have to develop a strategy to get to individuals. During the tsunami, somebody was going around our local swimming pool asking people to clear out their medicine cupboards so that they could send things to Sri Lanka. And my daughter said to them, no, this is something you must not do. So it's the individuals, I think, who are a major problem. And I think if we could somehow document a strategy to reach individuals as well, I don't know how.
So your suggestion is to develop recommendations for the individual donations?
No,
in the country.
You've talked about having blacklisting organizations, etc., but we also want individual local clubs and those sorts of people to be able to have access to the information. So if we could somehow, well, at least say that we need to do that sort of thing and then work out a strategy how to do it.
Thank you very much. The next one. Yeah.
Libby Ruffhead from the University of South Australia. Just to follow on from that, Rohini, I'm really sorry our country might have sent you stuff. What Australia tried to do was issue a press release and get the drug donation booklet, our guidelines, on the front of the Department of Health website at the time that the tsunami happened. So I wonder if what we're saying is into the guidelines themselves, we need to issue something like that, that donor countries might like to put out press releases for their people to say, don't donate, go through agencies or something like that to get it into the public press.
Thank you. Dr. Sana?
I have one point. I think that we need to recommend that working in governance on the pharmaceutical sector alone would not work if the overall governance of the country is weak. We need to recommend that we need more research and work in the governance function within the government. The capacity to set regulations, to set systems, mechanisms, because we can't work with the pharmaceutical sector alone, and all other partners are weak and they are not on the same track, because sustainability comes from different approaches, from top to the grass root level, and the same way. So we need to work on governance in a total holistic approach.
Thank you very much. And we have raised hands. Please, microphone back.
Chanvit Talatep from Ministry of Public Health, Thailand. I have one recommendation. I think the countries that have corruption scandal would not be a problem. But the countries that have no corruption, it would be real problem in the letters. So this should be mentioned into the recommendation. The second one, I think we need another research question about what is the impact and outcome of the national GGM frameworks to the pharmaceutical system in the countries. That would be improve our WHO GGM project a lot if we have the answer of this question. Thank you very much.
Thank you very much for your suggestion. And please write right now before the lunchtime and give to our repertoire your suggestion. Okay? Thank you very much.
Can I just add my research question on the impact on environment?
Yes, to wrap up, I just want to make some comments about the policies issue. The first is corruption is a pervasive and complex problems that can affect the healthcare access, equities, and outcomes. Therefore, the wide comprehensive anti-corruption developed by government may be needed. The specific sector-specific solution could also be pursued at the same time. And in order to be effective, reforms to combat corruption must be informed by theories, guided by evidence, and adapted to the context, as my studies show. And why systemic factors of the structure, management, and governance of healthcare can contribute to corruption, individual factors and social issues, characteristics may also influence the response to corruption. Therefore, it is necessary to be considered in developing the anti-corruption programs. For the future policies, I think we need, because the lack of enforcement itself is an opportunity for corruption. Therefore, future research should focus on explore the way in which enforcement can deter corruption in the health sectors, including cost effectiveness of alternatives, strategy for detection and enforcement, such as strategy for the fraud control unit, trainings of internal auditors, surveillance system. And also we need to designing and testing the anti-corruption programs and intervention. Thank you.
Thank you very much. Before we close the session, we're approaching the lunchtime. I really want to thank our panelists today, because I know that doing research on good governance and on issues of transparency and accountability and on corruption in national settings, it requires courage. And I know that during these periods of research, Yani, you make as many friends as you step on people's toes. So I want to really acknowledge your courage in doing research in this area and in trying to make these research findings publicly available. And to the participants of our session, I want to thank you very much for your active engagement and for your interest in this area. To our participants who are participating remotely through webcasting, both in Alexandria and the rest of the parts of the world, thank you very much. To our rapporteur, thank you. You've done a pretty good job at summarizing this, and we look forward to the final. Let us know if we can help. And to everyone, enjoy your lunch. Thank you very much.